speaking of passionate, I get the honor of introducing our next speaker, who is, I might have introduced her once or twice before, I think, over the years. I think I tell her I have the personal record for, I think, most introductions of her, but I can, which is wonderful, because I can never say enough great things about the Mental Health Commissioner, Dr. Ann Sullivan. Dr. Sullivan has a vast knowledge of our field, but more so, she is such a wonderful collaborator, and this is why this event today, as I said in the beginning, there are so many parts where we can be working together so successfully, and I think that with her leadership and you know, in Commissioner Neinfeld's leadership, I think we're going to see some real collaborative efforts moving forward here. So we're very excited about it. So Commissioner Sullivan, if you'd like to come up and speak, thank you.
Hi, good morning, everyone. That's a hard act to follow, Dr. Margolis. And I do want to say you set the stage for a lot of what I'm going to be talking about, and I really appreciate your comments, because I think they're very wise. I came in towards the end, so you didn't hear the whole thing, but definitely the last ones which pertain. First of all, it's a real pleasure to be here. I want to thank Mike Alvaro and Glenn Liebman and Harvey Rosenthal for inviting me today to be here. I think this is a critically important summit where we begin to get together and talk about really treating the whole person when someone comes to us. And I think that you'll hear from me, and later you're going to hear from Commissioner Neinfeld, and I think you're going to hear that we're both on the same page with this, and that we've already begun to look at a number of initiatives, but also to take very seriously, for example, the comments that you had earlier, Dr. Margolis, about respite beds and what might be needed in the system, and to look at what those models might be going forward. But before going into that, I just wanted to thank you all for what you do each and every day. I think that since this pandemic, all of our systems of care have been so stressed, but everyone here in this room continues to do all the hard work of serving individuals who need that help in New York State. So on behalf of myself and the governor, I want to thank you. I want to thank you for what you do each and every day. And our job, my job, is to try to make what you do easier and better. So I think that's what this dialogue is about. How do we work together to provide even better services to all the people that we serve? And so I'm going to talk a little bit about what we're thinking of. It's certainly not as comprehensive a plan as we would want, and we'd like feedback. And I also want to congratulate the association on their Crossroads document, which I think very clearly outlines the issues and some great suggestions about what to do about the problems. So let me just talk a little bit about this collaboration, this concept of integrated care, the whole person. I think, as you hear and as you know, our systems have been unfortunately siloed in ways which we do a lot of good work in those silos, I'm not saying we don't, but when it comes to complex individuals who have both problems, we haven't been as good at providing the services that individuals need. And I think we have to work together to do that. I think it's two things. I think it's somewhat the silos that our systems have built. I also think it's the education of our staff and our providers to understand the cross issues that happen. And I don't think we've done as good a job often in terms of training. And that's why sometimes people close doors because they kind of don't know what to do. And other times it's our regulations and the way we're designed and the way we pay for things that can be obstacles. So there's many pieces, I think, that have to come together if we're going to fix it. And I think that we have some ideas, and it's going to take some work. And we certainly need your ideas and your assistance in how to do this. So I just wanted to talk about a couple of things. First of all, that we've been doing in there was just a meeting yesterday with the three commissioners, that's OASIS, OMH, and OPWDD, and the county mental health hygiene directors. And that's going to be something called the Interoperating Coordinating Council. It's got a fancy name. But what it will do is actually bring together for an ongoing dialogue and ongoing discussion of how to fix things. Let me just put it that way, how to fix things. So that began yesterday, and that's going to continue, and there are already some good ideas. Then there's the summit today, and I think that that's an ongoing partnership of community-based providers and the leadership in the state to try to do these services better. I also want to talk about a couple of initiatives that we've started, just so you know that we're really committed to this. About a year and a half ago, we established a dual diagnosis treatment unit for adults at Kings County Hospital in New York City. And that was something which was done, that crossed over regulations, that was financed better than some units are financed, because we knew that they would need additional staff. And also a step-down unit associated with that, which was run by OPWDD, so that individuals who couldn't leave that unit and go home had the time to be in a residential program anywhere from 3 to 6 to maybe 9 months to get ready to go home. And while it hasn't solved all the problems of adult individuals with dual diagnosis in New York City, it's been very, very helpful. And the other thing we're doing there is establishing a consultation center, which soon will become broader across the state. We have, part of it was gathering together the expertise of individuals who knew how to work the very best with individuals with dual diagnosis. And so now we have that core group of staff, and we're going to be expanding that in terms of a learning environment and a learning collaborative working with OPWDD, so that that expertise can be spread across the state in terms of having availability of consultation, etc. That's not all up yet, but that's something that we're going to be working on. The second center of similar to that is one that will be opening in, I think it's the fall of next year, fingers crossed, in upstate New York, in SUNY upstate, for youth. And that's going to be a specialized dual diagnosis unit for youth who have both developmental disabilities and mental health issues, connected with a clinic system and a step-down system for youth. And that will also be available. I mean, so far it's only 2 things across the state. If these work, we will be expanding these in other parts of the state, and will be available again. SUNY has working with us to make sure that that unit also becomes a consultation, an availability consultation center to do work. Now the other big thing, which Dr. Margolis got started to talk about, is across the state, you know, we're developing a crisis system. And the crisis system of mental health involves 988, the number you call, and I hope you've all seen the advertisements for 988. And it also involves mobile crisis units, which is individuals leaving, individuals in the community, a team that can come and assess. And then it involves crisis stabilization centers, which are there for anybody to walk in or family to bring, etc., if you're in a crisis. What we're trying to do, and it's a big lift, is make all of those services no wrong door. So that anyone who comes in, whether they have a drug use problem, whether they have a mental health problem, whether they are individuals with developmental disabilities, that they can be served in those settings. So what does that mean? That we're upping the training for our call center for 988, so that they know the services, what's available, and that they are also trained to be able to provide some counseling to a family member who might call, or someone with a developmental disability who calls. 988 is a counseling line. So basically, the average length of time somebody spends on 988 is 20 minutes. It's not like you just say hi and you get a quick, you can talk longer, or it can be shorter. But 988 is really there, and we want to make sure that we have that line also available for individuals with developmental disabilities. So we're doing training that's getting up, we're not right up to speed yet, but it will. Similarly, our mobile crisis services have traditionally not been well trained. There's a great pilot in Erie County and Wyoming County that was done by the county, and they did a wonderful job, and we're looking at that in terms of integrating the training so that that mobile crisis team in those 2 counties can respond to both individuals with developmental disabilities and with mental health problems. And so we're going to be looking at that model, and then we're going to be training our other mobile crisis teams across the state. It will take a little time to push that out. And similarly, with the crisis stabilization centers, now they're not up yet, so this is good, because this means that our training for those individuals, as we open those centers, they'll probably open the first one, well, some are open now because they had been grandfathered in, but the newer ones, probably within 6 months to a year, there's going to be extensive training on substance use, mental health, and developmental disabilities. And we'll be coordinating those stabilization centers with the service system. So we're really kind of working on this. Now, it's not going to be without its kinks. This is a very different cultural approach for our centers, and we have to get people well-trained, and they have to really know the service systems of all these groups of how to connect. But we're really working very hard on this. There's another point which we haven't got the model yet, but I think Commissioner Neifeld will mention. This is looking at the issue of short-term beds for individuals who are dually diagnosed, whatever you want to call them. We call them crisis respite beds on the mental health side. I know there's a crisis respite system in OPWDD, but it's really not often for the youth who's in really acute crisis, and sometimes they have trouble getting into those beds. So we're looking at, and we haven't finished it yet, a design for piloting some beds that would do what you had mentioned, Dr. Margolis, have that availability for someone when they're in an acute crisis and they have this dual diagnosis, to have a place to go if they need to. And it would be a transitional beds. So we're looking at that. The other thing, which will open soon, we have a model in mental health called home-based crisis intervention. And home-based crisis intervention, this is actually state-funded programs, so it's not yet reimbursed by Medicaid. We have about 3,600 families in mental health in this program. And the home-based crisis intervention is a team that goes into the home and will work with only its caseload, maybe 3 families. And that team can work with that families intensively for, they often work with them for 6 to 8 weeks, 10 weeks, the longer if necessary, often to prevent hospitalization, but also post-hospitalization. And to help the family in vivo really learn how to follow some of the practices that can help them work with their youth. 2 of those teams are going to be soon, there's going to be an RFP going out to establish 2 of these teams that will focus on individuals with dual diagnosis. And those teams will be trained, co-trained by OPWDD and OMH, and in those teams, as a pilot, we will see if that works, and that's something that we will again expand. We've never done that before. We've never kind of really integrated, because certainly working with some families with youth with developmental disabilities, you really need a different level of skill set than we traditionally have in mental health, so we really have to get people well trained to do this. But this should be happening soon. Yes.
Just a point of clarification, you used the term dual diagnosis a few times. You're referring to IDD and MH?
Yes.
Okay.
Yes. Yeah. I'm sorry. Yeah. So this is focused. These 2 teams will be focused on MH and IDD. That's their main focus. We're doing a lot of integration on the substance use side too, but everything I've been talking about has really been between the 2 agencies. So I think this is a very exciting model, because when we think about some of the youth who kind of in emergency rooms, I think you probably need 2 things. You probably need what Dr. Margolis was talking about, which is a respite situation for youth who can't go home. But then for a lot of them, I think if you had a team that met them in the ED and the next morning was there to work with the family, you could avoid even the respite. You could avoid those things. So we're working on this to see if this is a model that might work. Well, it's always interesting whether something's funded by Medicaid or not, but one of the good things when it's not is the flexibility is incredible. So those teams can do whatever they feel that's needed. So it gives us a chance to really understand what the model will be, but before being constrained by what sometimes are your funding streams. So this is very exciting. We're going to be working on that, and we're really looking forward to moving it along. And then the other was what I mentioned earlier, just to mention briefly, the whole issue of training. And I think that this is something that we have not paid attention to in the way we need to. And I think some of you are probably well familiar with the ECHO model, where you basically do a combination of, it's virtual, but it's virtual, it's not online learning, it's virtual with case conferencing and people presenting cases, and also a didactic piece. It's worked very well in working with individuals, elderly, and especially individuals in nursing homes. One of the first ECHO project was working with multiple nursing homes many nursing homes across New York State, in terms of integrating mental health services into those nursing homes. So it works well when you're trying to integrate things. And that's something that we are in the process with Commissioner Neifeld of designing now, and we have money for this, and this will probably become live next year as well. And what topics we will use, the focus, etc., is something that we will be deciding jointly. But I think it's a way to spread, it's using technology to spread the training in a very useful way that I think can be very effective. And it really gets down to the level of case conferencing and stuff. It's not just a didactic presentation, it helps people learn how to do things. So those are some of the ways we're going, from the intensive services particularly, and then also to the crisis services. And then the last thing, which we haven't done too much on, but I think we have to begin to think about, is our clinic systems, and where those clinic systems need to have this overlap. You know, what's fascinating is that many providers of clinic services for the developmentally disabled and mental health are the same provider. They are under the umbrella of the same organization. But partly it's been our regulations, the way we fund things, the way we require things that have helped keep those silos and keep things separately. But the good thing about that is that that means that there's a number of our clinic providers who have expertise in both. And if we can kind of pull that together and help them learn better how to work in the clinic system and how to train, I think that that's a kind of strength that we haven't utilized as well. So that's the next phase that we will be, and we need a lot of advice from you guys on that too, as to how to do that. So that we have, for many years, I had a substance abuse clinic at a hospital I worked at, and a mental health clinic. And literally, they were in the same building. One was down this aisle and one was down this aisle, and they never talked to each other. So it's fascinating how we worked at it, we got them to finally talk to each other, but they were very separate. And I think we have some of that in our clinic systems, and I think we can work at that. And we can work at what people will say very quickly is, well, your regulations and the things you do, and we'll work on that. We will work on that together to see how we can improve that and that connectability too. So all I want to say is that Commissioner Neifeld will kind of reinforce all this, that we are really working very, very closely together. And it won't happen overnight, but I think with your suggestions, your help, and with working together, I think we can finally begin this process of really, truly integrating care. So I'll stop there. Any questions or?
You talked a little bit about ECHO and working with seniors. In the IDD world, there's early onset that we see, and they aren't necessarily constituted or seen by the Office for the Aging as old, and a senior citizen because they're under the age of 55. So I just encourage us to not forget that in the process of aging, that too is a spectrum of needs and supports. And nursing homes is but one place, but we have quite a few people, and I say that tongue-in-cheek, that need that. And then add to that any communication needs that they might have. We have many people in our state that have hearing loss as we age, but also as a primary challenge to the world and the hearing world. So not forgetting all those other kinds of things that tie into that would be key to this too. So we've got to be a little bit more holistic in all things looking into it.
You're absolutely right, and I think we don't often pay attention, as you said, to the lifespan and the importance of things that change. Things change. We're working in our housing programs. We don't want to have our people in our housing programs to have to leave where they've lived for all these years because now they have more medical issues that make it difficult. So how do we fix that? How do we design it? It's the same thing, I think. And so yes, we have to integrate it, and we have to continue to be reminded about it because it's very easy to get focused on a piece of the puzzle and not see, the whole lifespan. So thank you. Yeah, very much.
Okay, I'll jump in. When you talk about the Project ECHO, which I'm really excited about that, and also thinking about from a clinic perspective, so outpatient treatment, preparing clinicians to be able to really, from a cultural perspective and from a practice perspective, provide competent care to a whole person who has IDD and mental health concerns. How do we create the systems that will allow that effective training, reimburse for lost units of service, and provide a model that has mentoring and support ongoing to ensure, so you can send people to a one-day training. And I operate a clinic, so I know that the cost to sending that person or persons, all of my supervisors, all of my staff to a 1 or 2 day training is not enough. I can spend that $5,000, but there's also the lost units of service, and then a one-shot training does nothing unless you have ongoing support and ongoing coaching to ensure that those skills that are learned are being effectively used. So,
and absolutely, the way there's several things you brought up that I think are critical. But just to echo for it, the way the ECHO thing is designed, it's a learning collaborative that's ongoing. That's the first important thing about it. So that basically, it's usually about an hour, maybe an hour and 15 minutes. There's usually a little bit of a didactic part, and then there's a discussion of cases, and then there's time for questions. And it could be as frequent as once a month. It could, or infrequent as once a month. It could be once a week. What some places have done, and it's sad because we often don't reimburse for time lost, have done this, 1 hour a week or 1 hour a month. That they just eat it. I hate to say, they eat
We
the
do.
cost.
Yeah.
Or you eat, or some places do it at lunch time, and for voluntary, which isn't as good because I think that that's not good, but it can be done. So people have adapted, but no, it's not easily paid for in terms of time. But I think what you get if you can financially survive, and I realize that's an issue, it does two things. One, it trains people, but I think that's a retention issue. I really do think that people come to our services and stay with us and work with us, partly because of the work and the care and caring about people, but if we can offer more in terms of educating, I think that's another reason to come. Because if you're out there in private practice, you're on your own, But if you have a community of learning, and this is something that we've tried to do in some of our hospitals in the state system, it helps with retention. We found our nurses stay because we do a community of learning around the nurses. We give them the time, and it costs us. We give them a half a day, a month of just learning. You don't have to be on the unit, you don't have to be and this is for our young nurses. And it keeps them. We haven't lost as many. So I think it's a combination, but I agree it would be great if we could reimburse. Now, we always fight for higher rates, and this time we did get some higher rates for our clinics, and one of the things that you can use those for, perhaps, is to be financially stable if you do give up an hour a week or something like this. But yes, it is an issue. It is an issue. But I think the ongoing piece is critical. It doesn't work just with a one lecture or 2 lectures. You have to have the ongoing. The second thing, which is not exactly ECHO, but is we set up these centers. They will be available for consultation. And I think that's where we have a program, Project Teach, which is child psychiatrists. This is paid for fully by the state. Any pediatrician or any psychiatrist as well can call and get a consultation free of charge with the teams of child psychiatrists that we have at various university hospitals. It's tele or telephone or telehealth. We are thinking of adding, and we may be able to these are physicians, so it's not the whole spectrum of education, but adding individuals with specialties in developmental disabilities, crossover mental health. And we're close to doing that, and we probably will be able to get somebody online to do that. That's free of charge, so your clinicians can call and get, and we've had a great response from pediatricians. One of the big issues with areas where there's a shortage of child psychiatrists is that the pediatricians don't know what to do. And now they have an ability, we've had it for several years, they use it a lot. They call. We also do some didactic stuff if the pediatrician's interested, but they don't have to participate. They can just call because they're seeing a child and they have a question. And I think that's what we want to have increasingly available. And I think we would probably do that for psychiatry, and then other things we'll be thinking of for other consultations, which come up in various sites. So yes, so you need the consultation, you need the kind of ongoing learning, and we're trying to see how much we can build that in, because otherwise we won't. The other thing, which we have not done, but I would love to do, and any of you connected to universities or training programs, is start this integrated training when somebody's training. We end up training people after they've been trained, and it's like you're trying to push, in something when people's culture isn't that. So I think we're having discussions. It's a big lift. It's not gone very far yet. But if I think of my background as a physician, I can tell you that, well, that was a long time ago, but I honestly don't think it's changed, that I had such limited training, even as a psychiatrist in developmental disabilities. Limited training. It's amazing. And how you coordinate care. And I would bet it's still not that robust in our training programs, unless you come in with an interest and ask for it. That's not the way it should be. It should be integrated into the learning. And that's where we begin, so when people graduate, they're at a different point, and then they can, just like with everything else, continue to learn. but not have to start almost from square one, you know, in terms of learning how to integrate practice. So that's a big lift, and if any of you have connections with university, we've got to get on that pulpit, I think, a little bit more to get our training institutions, social workers, psychologists, psychiatrists, everyone, to really integrate before somebody, that they get that experience and they know how to do it.
Just, I wanted to, well, thank you first of all for that, because that training piece is something that Dr. Margolis touched on as well. I think it's something that it's so fundamental that it will take a partnership to change the way, you know, the requirements are so that it's done early rather than late on top and it's sort of extra. So I appreciate that. And the other piece was on the clinics. We've been talking for years about, we have folks that hold 16, 31s, 32s, and 28s. And, you know, it's very hard with all the administrative pieces of that. And some of the clinicians do work in ones, but not always. And the point of this is that we're going to have a series of conversations throughout the room, and we'll have for you, and Commissioner and I felt this here as well, we'll be summarizing all the recommendations, and I think those are absolutely two that will come out of this, the themes of training, and then getting rid of that administrative.
Yeah, I think there's an increased interest in doing that now. You know, when you try, you know, when you do these things, it's always, I always say, it's timing, and then there's timing, you know. So if that was a good time to try to break down those regulatory barriers. So I think your recommendations, the practical things that we can do, we will be working on. Now, some of them are out of our control. Some of them are stuck with the way the feds do things and the way they require, but some of it's in our control. And I think we have to look at what's in our control and see what we can do.
Thank you, Commissioner.
Thank you.
Thank you so much. There is so much symmetry here. It really is. I mean, you know, talking about Project Teach, talking about 988, talking about all of the programs and initiatives that are going on, it's just, the time is right, and I think that's where we should be moving in that direction. So anyway, I have the pleasure again of introducing Commissioner Neifeld. She used to work on the second floor and did mental health as one of her many areas of expertise. So she does have a great understanding of this. So it's great to have her knowledge, Commissioner Sullivan's knowledge. There's really a lot of integration that's already happening, but will continue to happen in the future. And we're lucky to have her. So, Commissioner?
So I'm really just here to say hi. I was not planning to be here, but coincidentally, the other meeting that was my conflict was right next door. So I'm able to come over and say hi. I think later on, Rachel Baker from my office and Sarah Kiriakos from OMH will be here doing more presentation on some of the work that we're doing together. And I missed what Dr. Sullivan said, but wonderfully, she and I have been on the road together all across the state talking a lot about the work that we're doing. So I can imagine what she said and what she shared with you and reinforce that we're really working in partnership. And I guess maybe for the first time, that's what we're hearing, I think, as we go across, is that it's been a long time since providers and local government have seen this level of partnership on the ground, but we're very committed to it. And I think with our other partner agencies at the table, and certainly, with a very supportive governor and very supportive legislature, I think we really have a really great opportunity in the upcoming years to really try to make a difference in some of the areas that we know we've struggled with for a long time. And certainly, individuals with, developmental or intellectual disabilities and co-occurring mental health disorder is an area that I know I hear from all the time from our providers as an area of struggle. And I know that as we, are spending more time with the Conference of Local Mental Hygiene Directors, more time with departments of social services, commissioners, at the local level, local government, right, we're hearing it from everywhere. And the message that I take away, right, is that, we at state government level have to stop looking at people as silos, right, as belonging to OPWDD or belonging to OMH or OCFS or OTDI, whatever the primary diagnosis is, right? And I think what you have is really committed partners to doing that, to breaking down those silos, to being able to work with our partners at local government, our provider partners, the people who are accessing services from our organizations, to help holistically serve them, right? And to recognize that someone with a developmental disability can also have an experience with the mental health system, or you know, the homelessness system or whatever other, right, of these sort of systems that we create that sort of, you know, serve to label people and give them, you know, a diagnosis code, and then that's the waiver that they're in, you know, and so really trying to spend some time breaking that down. And, you know, I guess what I have found over the last several years in my time in the governor's office and my time at OPWDD is that it's easier said than done. And so I think a lot of time, you know, you'll see initiatives start where we're committed to this, and then because it's difficult to do, you know, other things take precedent, right? And, you know, people are busy, you know, and it can become hard to do that really, you know, difficult systemic work of breaking down some of those barriers. But I think we have committed partners at the Office of Health Insurance Programs, which is right our Medicaid office, where a lot of some of these silos and some of these barriers, especially with funding, you know, sort of derive from, and really, you know, committed to looking at, you know, where are those areas that we're, you know, artificially siloing people and making it harder for us to serve, you know, holistically. I'm sure that Dr. Sullivan talked a little bit about some of the areas that we're partnering, and I know that Rachel and Sarah will talk a little bit more about some of those areas, but we're really excited to continue to partner with OMH on those areas, and also on our own initiatives, which Rachel will also go into later, but our own initiatives around, you know, crisis intervention, around, you know, putting into place and into practice more transitional adult residential opportunities that can help individuals coming from institutionalized settings who are maybe getting stuck in those institutionalized settings because we don't have anything in the community that's appropriate, developing those appropriate community opportunities, working, I think, with OMH on taking advantage of the wealth of information that's already out there, the training, the volumes of trainings that have been developed that haven't necessarily been, you know, utilized in the best way, and really trying to take advantage of that, make sure that the people who are working in our system, you know, are trained to understand what is a co-occurring mental health disorder, right? And I think vice versa for the mental health system. You know, we're doing a lot of partnership on mobile crisis, which is an obvious area for partnership, and, you know, helping to build the capacity of mobile crisis workers who are interfacing with people who have co-occurring disorder or just people who have IDD, right? And we had a really great, you know, conversation yesterday with some of our partners who are here, right, from local government, with reconvening the IOCC. And so I think, you know, we're committed to continuing the work. We're committed to hearing from you guys who are on the ground practicing every day, doing this work, what's working, what's not working, where do we need to make improvements, and continuing to have that dialogue and that partnership and trying to make change, and, you know, committing to, you know, hopefully continued positive incremental change that will happen over time, right? And I guess that's the thing that I just want to emphasize is, as much as we want a lot of these solutions overnight, some of them do come, you know, with that sustained effort, and over time, I'm confident that we'll see those shifts. So, you know, I didn't have a script, so I have no idea what I said. But I hope you guys enjoy the rest of your conference, and I'm sorry that I couldn't be here with you later this afternoon, but I know that Ann and Sarah, you know, are ready to talk more and to take questions. So,
Great.
yeah,
Thanks so
thank
much.
you guys.
Appreciate it.